All right, thank you, everyone. I'm Dr. Jeremy Whitaker, and as Gina makes me say every time, a board member of the Iowa Public Health Association, even when I talk to my own mother. We'll start off with our first panelist today is Casey Parnell, a proud Branson, Missouri native. Casey's part of #HealthierMo initiative. We're striving to improve the public health system for the benefit of everyone in Missouri. She completed her Master's of Public Health and Master's of Public Affairs in 2013. She has since worked in both county and state public health settings in the field of alcohol, drug, and tobacco use, prevention, and policy development. So, Casey?
Thank you. My name is Casey Parnell. I'm the project manager for this new initiative in Missouri. So the initiative is now called #HealthierMo. We originally had this long name here, Transforming the Future of Public Health in Missouri. And it's not that we've dropped that. We just understood that that was hard to convey and hard to understand and probably a little wordy. So we've shortened it. So hopefully this makes sense for folks. And of course, we're doing lots of media, so always include the hashtag. So I just wanted to explain that. Some of you have probably heard like Robert Niscoda talk about this project, and I wanted you to know that they're actually the same thing. We just recognize the need for the change in the name. So today I'm just going to do sort of an overview of the project, a little bit about the history, and then what we've accomplished in phase 1. And of course, I always have to recognize our funders. The two largest health foundations in Missouri have come together to work on this project. They recognize the need to address the public health system, and so we're very grateful for their support and their ongoing support. So first thing I want to show you is what we have really put a lot of work into is our website, and I would direct you there. Everything that I'm going to talk about today is on the website, or nearly everything, and then if you have any other questions or can't find something, you can always call me or email me. But our website is healthiermo.org, and that's our landing page, and then within that is all kinds of information. You know, one of the things, before we started phase 1, which started in September of 2017, we did a lot of background work to make sure that we were approaching this project from the right direction. And one of the things that we heard were there's some keys really that would make this project successful, and we've tried to keep those keys in mind as we've gone through this first year. One of those being transparent and good communication. So in an effort to meet those key recommendations, we have created this website where we house all of the meeting minutes. Essentially, all of the information that we can share, we put on the website. So I would encourage you to go and check it out. So brief history real quick. This actually started in 2014 with a group of public health leaders in the state sort of recognized the need to address public health. You know, things weren't working, and you can see from the slides today that were presented earlier, Missouri is struggling in many ways related to public health. So they did, as I said, they did some background work, did a lot of surveying, got some feedback from folks, and they did learn quite a bit in order to guide this project forward. So what they heard was that there's a lack of systematic coordinated efforts, and there's a lot of variance because we have 100 and up until last month 115, but now we have 114 locally controlled health departments, which means there's all kinds of stuff being done but not necessarily being coordinated. And then there's not a single funding system either, so all of that's kind of disjointed and needs to be addressed. But then on the other hand, so those were the challenges that were identified. They also heard a lot of optimism, a lot of support for doing something, for taking some action, and so people were willing to get behind the project as long as it was being done in the right way. And so one of the other keys they identified to the project's success is putting the right leadership in place. So all of that being said, They submitted a request to Missouri Foundation for Health. Initially, the plan was big. It was multi-year. It was millions of dollars. And Missouri Foundation for Health came back and said, no, we're not doing this. You need to rethink the plan, think through things stepwise. And so they came back with a new proposal, and it's broken into phases. And so, as I said, phase 1 started in September of 2017. They hired staff. I came on board in October of 2017. We also have a communications coordinator as staff. And then we also have somebody who's doing our administrative work, and she's wonderful. Her name's Sandra Beckman, and Jackie McArdles is doing our communications work. So we have 3 staff. We also have some contractor workers who are helping us through this process. So we are grateful. Like I said, we have 2 foundations funding us through phase 1. They are on board for phase 2, and we are in the process of writing the proposal for phase 2. So I want to share with you today mostly what's happened in those 8 months since September, and I feel like it's a whole lot, so I'm going to do my best to squeeze it all in. So the proposal for phase 1 included 2 main goals, one of which was to identify public health system stakeholders, leaders, and vision, and the second was to align Missouri's public health professional organizations. So we'll tackle these one at a time. The first one I want to talk about is goal 2. We have a lot of organizations in Missouri that address public health, but when we looked at it, they weren't working together. And you go to the Capitol and you say, I'm from Mo whatever, and they're like, well, that's just another group. Why should I pay attention to them? This other group is saying something else, and blah, blah, blah. So there was not the coordination that we needed in order to have a very powerful voice in public health. So that's the idea here. If we can align what these groups are doing, we can have a more powerful voice, especially in the realm of policy making and advocacy. So that is our intent. You can see the list of organizations that are involved right now. We actually, I think, are going to be bringing on a public health nurses organization as well. And I'll tell you what we've done thus far is we have a monthly meeting, and all of these folks come together. They send 1 or 2 representatives, and we meet in Jeff City, and they dedicate a whole day each time they come. And we, thus far, in 4 months' time, we've been meeting since January, have essentially gotten a commitment from all of these public health leaders in the state to come on board with this project and to stay involved even if the funding were to dissolve, which is pretty amazing. In that time, we've also developed a vision statement, which is United for Public Health. We have a mission statement, which is leading public health system alignment through collaboration, communication, and workforce development and advocacy. So we have the vision, we have the mission. Just last month, we developed goals for phase 2. In phase 2, we don't have outlined yet a starting date or essentially a timeline, but we're hoping within the next 6 months to start phase 2 of the project. So this group is going to keep working sort of regardless of how the funding and everything works. They are moving, and they're going to stay on their path. And like I said, I have been personally really impressed by the level of commitment. I mean, we're talking about administrators and directors of public health departments that are dedicating a whole day a month to come together and work on this project. These are the goals, and I'm not going to read through them all, but a lot of it is around we say we want to work together, we say we want to have one voice, but what does that actually mean, and how do we define that, and what's going to work best for everyone? And so a big chunk of the work for the next probably year of this project is going to be developing that structure. And right now we're talking about one of the big concerns in all of this, of course, is that each of these groups has their own membership, and they have their own dues, and they have their own conferences, and they have everything going on. So how do we coordinate that in a way that they don't lose their identity, and the people involved don't feel like they lose their identity along the way? So keeping that in mind and listening to the feedback, we are considering at this point the structure might be a coalition type framework where everybody maintains their own identity, but somehow we make it more accessible. So if I work in a local health department and I want to be involved with this group, but man, I just can't join 6 organizations. That's a lot of money and a lot of time. Somehow integrating those things so people can be involved to the degree that they want to be involved, and that we have that voice, identifying some priority policy issues going into the next session. Missouri has a 5-month legislative session, so we have time over the summer and the fall to sort of plan out our priorities and get ready for the next session. So that's going to happen this summer. So that's what the professional organizations group has been working on, I would say have been very successful in moving the ball forward. And I feel like a lot of that has been due to the fact that those leaders have been very committed to participating. And so I thank them for that. The other goal of phase 1 of the project was to reach out to our public health system stakeholders and listen and gather feedback about how they want this project to move forward. So you all know that when I say public health system, that is a very broad group of people, and it's sort of like, well, how do you define that, and who all should be included, and we don't want to leave anybody out, but at the same time, well, you get too many people in the room and then you can't be effective at getting anything done. So it's been this sort of balancing act. So we started big, and we aimed to hold what we call the stakeholder convening session. And we held that March 1st. And we had over 120 folks, public health leaders from across the state in the room. And we also had some other folks. We had nonprofits, and we had hospital systems, and we had essentially anyone that we could think of that would have some direct tie to public health. And like I said, again, another amazing show of commitment that these people would show up, give a whole day of their time, and we very much appreciated that. So the point of that was we get all these people in the room, and we start gathering, asking from them the big questions. What is your dream for public health in Missouri? What does a well-functioning public health system look like here? How do we get there? Who needs to be involved? All of those important questions, knowing that the next step was to form an advisory council, which would be a group of people who will take all of that information, look at it and go, okay, here are the things we need to prioritize, and here's how we do it. Here's the next step. So we asked them specifically to help us identify who should be a part of that advisory council. Again, so that we aren't leaving those important people out of the process. Forward. So I thought I'd just share some of the feedback that we got from the convening, because it was really enlightening, and things came up that were unexpected, and we've been able to use this data, I think, pretty well. So we asked them what one word they would use to describe the project thus far. And so you see most of these are pretty positive words. Progressive, innovative, change, I think all good things. And I should note that the bigger the word, the more times it was used. So sort of make this word cloud. I would note that our communications coordinator, Jackie, is amazing, and she makes all kinds of awesome graphics, and I just love it, and you'll see them on our website. But so we also asked them what they thought the top reasons for transformation of the public health system in Missouri were. And of course, not surprising anyone, was funding. And number 2 was unified voice, focused on priority issues. And then number 3 was coordination across agencies. Again, sort of all those things that we listed, we heard even back in 2014 when we started this process. So no big surprises there. So we asked them, we eliminated the top 3, and we asked them to prioritize the bottom of the list. And then we heard, okay, higher quality and more consistent operations, and prioritized by elected officials. So we've got, those are essentially 5 big topics to start addressing. Some of the other ideas that we've heard was identifying foundational services. We've looked at that model of foundational public health services, and we've started to talk about using that model potentially. We also heard lots of issues around workforce. A few years ago, they did a survey of our graduating MPH students out of Missouri to see where they were working in what fields, and it turns out we have a big retention problem. Most of them are leaving the state, and that's not good for our workforce. So that's another issue that came up. Of course, funding also, you know, it's just one of those things that's going to continually be an issue. Let's see. You know, figuring out if really there was enough support to drive this type of a project forward. And then the other thing that we heard over and over and over again is we don't feel like public health is valued in Missouri. And people don't know what we do. And you know, that goes back to the conundrum that came up yesterday, which is if you're doing your job well in public health, nobody knows you're doing your job. And, you know, there's only a crisis at which people think of public health. So, but we heard, okay, we need to do a better job of messaging. So messaging is on the radar. We asked folks if they bought into the project. Do they think that this is something that's viable, that we can actually transform the public health system? I mean, that is a huge deal, and that's going to take a lot of input and resources and time. And I mean, strongly agree and agree. We're looking pretty good, pretty good. They buy in. They were pretty on board. So we proposed to them a selection process through which we would place people on the advisory council, and we asked them for feedback. And so most of them felt pretty good about the selection method. We made some tweaks to it based on their feedback. So, over time.
No. 3 minutes.
Okay. Let's see, they agreed with the advisory council and the timeline for all the activities. Skip here. So one of the other things that, and particularly the foundations encouraged us to do, was to document what we're doing in the form of a case study. So we have hired some evaluators from Missouri State University who are going to be on board with us throughout this whole process. And so phase 1, like I said, we're about 8 months into the first year. We are just sort of getting our feet under us as far as the documentation is concerned. It's sort of, you know, it takes a lot of thought process to go into an evaluation. And so the case study is one element of that. The other element that we're asking them to work on is what we're calling perceptions. And that is one of the keys to the success, again, is making sure that people understand what we're doing, why we're doing it, they feel heard, they feel like they're being able to give input. So we are working hard to measure the perception of our stakeholders throughout this process. Surveys, I mean, we're going to do all kinds of stuff. So we're glad to have the evaluators on board. Let's see, we asked them if this group of stakeholders at the convening would be willing to help out in some way, and most indicated that they would be. They're willing to share the information and be, you know, we can't do, with 3 staff, we can't do it all. So we are encouraged to see that they are willing to be partners in this project. And we also, one of the measures that the evaluators came up with for the convening session was, do the benefits of participating in this initiative outweigh the drawbacks? So we sort of outlined what would be the benefits, what would be the drawbacks, and we were very encouraged to see that most people felt like the benefits would outweigh the drawbacks. So I think we're headed in the right direction. We've got them on board. They were satisfied. There's all of this data is available if you'd like to see it. I'm going to skip through some of it. So coming out of that convening session, we feel like the prognosis is good. People are excited about it. They want to participate. In fact, we've had one unanticipated problem is so many people want to be involved that we don't have a place yet for everybody. And we will, but it's a process. And so it's how do you keep people engaged when you don't have a way for them to be directly involved? And so we're working through that. We're thinking of ways to get people involved. A lot of it has to do with sharing information with their colleagues, with their partners, helping us build the network of support around the initiative. So there is, I mean, if we're being realistic, thank you, I'll wrap up here. If we're being realistic, there are some concerns around, they use the term viability, but I feel like it's, a lot of it is concern around, can we actually do this? You know, we've tried projects in the past that haven't really gone anywhere, and is this just another one of those? And do I want to invest my time if it's not actually going to go anywhere? So we've got some proving and trust building to do along the way, and we're working hard on doing that. But I just want to share one last thing with you. We're doing lots of communications work. One of the quotes from the convening that we had was, you have momentum, capitalize on it, and keep rolling. Don't let it stall out. That was our big takeaway. We have the support we want. Now we need to take the steps to move forward. We have formed our advisory council. We had our first meeting last week. This weekend, I will be entering all of the data and starting to analyze, and we're going to keep moving this project forward. And I want to acknowledge that a lot of the states, and Kansas included, we are looking at as models to help us move forward so that we aren't reinventing things. You know, let's make this easy as possible throughout this process. So that's where we're at, and I'll be glad to answer any questions that you have.
Right, thank you. And we'll hold questions till the end. So please write down your questions because it's hard to remember them. Say 45 minutes. So.
Thank you.
And next, I'll invite up Jami Haberl. I practiced it earlier. She's the executive director of the Iowa Healthiest State Initiative. She received her master's in public health and healthcare administration from Moines University. Prior to joining the Healthiest State Initiative, she served in various leadership positions, including as the executive director of the Safeguard Iowa Partnership, senior program manager of the CMS Physician Quality Reporting Initiative, and executive director of the Center for Disaster Operations and Response. So quite a resume. And this one.
Well, good morning, everyone. Like you said, I'm Jami Haberl. So I work for the Iowa Healthiest State Initiative, which is a nonprofit organization actually that was created here in the state of Iowa in 2011. And really brought together, it was led by 3 business leaders recognizing that government can't change the direction of public health or the health outcomes of Iowans by themselves, that this really needs to be done by collaboration between public and private organizations. So our role really is as an umbrella organization, bringing together public, private, as well as nonprofit organizations from across the state of Iowa to identify what are the opportunities, how do we leverage the very limited resources that we know that we have to really start to change the issue. So I recognize a lot of friendly faces that we work with in this room. So one of the, Rachel had asked me, which really I thought Rachel probably could do this presentation because she is one of these. So one of the programs that we actually launched last year as a pilot is called the Iowa Walking College. And so this was really, I would say, stemmed out of, there's a group of a wide variety of different partners that participate in called Active Living Iowa, which is led by Sarah Taylor Watts, who is at the Iowa Department of Public Health as our physical activity coordinator. And really that group is an informal group that comes together to talk about how do we get Iowans to be more active and how do we get Iowans to meet the U.S. Surgeon General's call to action to get 30 minutes of physical activity in our adult population. So Iowans, we tend to be we rank very poorly when it comes to physical activity as well as fruit and vegetable consumption, which we know are 2 major factors to having great health and living a long and healthy lifestyle. So the Iowa Walking College, really, that was kind of, it really came out of a lot of conversations of saying, what can we do? And part of it was there were conversations occurring in Iowa communities around how do we improve walkability. And one of the communities happens to be here in the Des Moines Metro, Windsor Heights, where there was a lot of conversation around not wanting to add sidewalks. And it became an extremely heated conversation. And one of the things I think that we all learned, you know, we would go to these meetings, but not being citizens of that community, our voice actually, they kind of would tell us to be quiet and not provide our opinion because we don't live in that community. And so that was really kind of an eye-opener for a lot of individuals participating in active living Iowa, is that we need to build local advocates across the state of Iowa that can speak on behalf of their own community and advocate for having more walkable communities. So it's been kind of interesting. I actually moved from a very walkable community to a very non-walkable community. And so I have always said, oh my, the walking advocate here now lives in one of these areas that is not very walkable, but I haven't opened that conversation quite yet with my neighborhood because I will probably not be very well liked because I want sidewalks, because I know what an issue it is. So our mission is really to improve the physical, social, and emotional well-being of Iowans, and our vision is very lofty, similar to what you talked about being the healthiest region. We want to become the healthiest state in the nation, and that's what we're working towards. So we have a long ways to go, but we know that we need to really collaborate and coordinate across all sectors, both private and public and nonprofit organizations. So I'm going to focus my time talking just about the Iowa Walking College. We actually just launched our second cohort of this week because of we had such great feedback from those who participated in last year's. So I have a video, see if it works.
Two-thirds of Iowans are overweight or obese. Americans aren't moving enough. We really want to create an environment where individuals have an opportunity to be more physically active.
You're talking about street design at the turn of the 20th century and gradually been widened to fit cars, and now they're no longer friendly to people.
I almost feel like choice has kind of been taken away from us in a way. We have to drive everywhere because of the way we design things, and I think giving that choice back to people is really empowering.
Walking College as a whole provides new perspectives, improves people's ability to understand policy and procedure. They have great speakers and valuable information for anyone who's looking to improve the walkability in their community.
The most valuable part of today was the walking audit, getting out into the community, getting to see two very different aspects of what can make a community more walkable.
City leaders are very reactive to what their residents are telling them they want to see. So if walkability is something you want to see improved, certainly standing up and being a voice for that is important. Otherwise, they're not going to know that that's a value.
We took our teachers out and administrators and the engineer for the city, and we walked across a highway where kids would be traveling to get to school. And then they realized how dangerous a situation like that could be when it's improperly marked. So they went ahead and quickly put in better signage, flashing lights, crosswalk countdown, better street panes to make it much more visible.
You could go to the Iowa Healthiest State website, and we have a whole section that links to a number of other partners, including Iowa Department of Public Health, AARP, and other resources here in the state of Iowa that can encourage you and provide you resources to actually do a walk audit or other walking programs that you might want to start in your own communities.
So that was kind of just our little advertisement that AARP helped put together to kind of help us talk about what the Iowa Walking College is. So this program really launched, and we borrowed a lot of information from the Permission of America Walk. So we had an individual that participated in the National Walking College. So there is a National Walking College that has been around for probably 4 or 5 years, and it's put on by America Walks. And the idea is that they will increase advocates across the United States around walkability. So the challenge with that, though, is there's only 25 advocates that are accepted every single year. And so when you think about like how fast can we move this movement, 25 advocates, not having one from every state even, is not a very fast way to make movement. And so we were fortunate that Ann Mansfield, who is located out of Decorah, actually participated in the first year. And she came back and said, why can't we take this program and make it and Iowanize it? Like, take it so that we can do more here in the state of Iowa. And we've had a big push around walking and walkability at the Healthiest State Initiative for quite some time. And so it made sense. And we know that walking is the most easy, affordable, and accessible form of physical activity each and every one of us can do. It doesn't have to happen all at 30 minutes. It can happen 30 minutes throughout the day. But there's huge scientific support around walking and walkability, and we know how important it is. So that was really the big push, I would say. So we talked with America Walks. They were extremely excited. CDC was actually very excited about us taking something from a national level and Iowanize it, as we like to call it. And so we took all of the materials that they had and really tried to scale back. The National Walking College is extreme. There are materials galore, and some of the feedback that Ann provided was it was a little too much for the 6-month program. So we wanted to make sure that it was reasonable because we recognize how busy everyone is, but we also wanted to make sure people were getting the right type of resources so they could stand up and actually be the local advocate in their own community. So it's piloted off of America Walks. We've tweaked it. After last year's pilot, we wanted to try and see how it would work, if it would be effective, what kind of feedback would we get. We were very fortunate that fellows that participated in the Iowa Walking College came from a wide variety of different disciplines. So you saw a lot of people on the video that were from public health. We did have a number of public health professionals, but we had a developer who's a vice president of development here in the Des Moines area that is doing a ton of development around housing development. We had some architects, we had some engineers and planners. So it actually brought, the conversation was very interesting because it wasn't just a bunch of public health people like us that all start thinking in the same thing. We all talk the same talk, we all walk the same walk. I mean, you had people kind of bringing in different perspectives, which was really interesting. I think also what's really important to recognize is that Iowa Walking College isn't just about health, and it isn't just about health benefits. That was one thing that was really important. I think if we're going to really move the needle on some of this, it can't always be coming from just the health lens. We have to be looking at what other people are thinking about. And economic development is a huge driver when it comes to walkable communities, and so we recognize that. And so we had a lot of conversation about, transportation, economic development benefits, as well as health benefits, which obviously is what we really care about and that we want to make move. But if we're going to engage people outside the public health field or out of even a healthcare field, we have to talk in their language, and we have to have them understand why this is so important, not just always from a health side, but from the economic development side as well. So it's really, it's a 6-month course that we put together, and it was really, we used a number of different partners across the state of Iowa to be our speakers. Ethan Standard, who works for the Healthy Hometown that's powered by Walmart. I mean, he does walk audits throughout the state of Iowa and is I would say an expert when it comes to walk audits. And so, we asked him to participate. We had someone from the Metropolitan Planning Organization participate to talk about how has transportation changed over time. Why are our roads so different today, and why don't we have sidewalks? What has been some of the policy changes that have occurred over the last 20, 30, 40, 50 years, so that we have a bigger understanding of how do we get to where we are? Why do some communities not have sidewalks? I mean, it seems kind of crazy, but there's reasons for that, and there's planning and transportation as well as engineering reasons. So we kicked it off. What we were fortunate about that's a little bit different from the National Walking College is we could do face-to-face. So Iowa, though, is a big state and people had to travel, I think our furthest was probably 4 hours to come to face-to-face. We really do find the value of building those relationships through that face-to-face opportunity. And so we kicked it off with a face-to-face all-day session, and then we did 2 webinars, and then we ended it with a face-to-face to kind of bring everyone together. We also had the opportunity to participate in America's Walk National Summit. It happened to be held in St. Paul, Minnesota, so it was very close, which made it convenient for the fellows. Unfortunately, that's not so convenient this year. But some of the feedback that we had was actually more face-to-face opportunities, and so we actually increased that. So they are meeting 3 times. We just kicked it off on Wednesday. They'll meet again in June. We'll do more of the online webinar in August, and then they'll wrap it up in September and come back together. But the idea is really to kind of build the mentoring opportunities with everyone so that they can share. And I would say from last year's class, I mean, Rachel and a number of the other fellows have been continuing to have conversations or asking questions like, hey, have you come up against this issue, or how are you handling this? Can you share policies? Those type of things. So I would say there's been a lot of coordination that's occurred because of that. And that's what we want as well. The other thing would be with the assignments that we do. So we have 6 different modules, and each of the modules, they have an assignment that they have to complete. And it's really something hands-on. So some of the assignments include writing a letter to the editor about the importance of walkability and sidewalks. Also includes presenting to your city council, which is something very new, I would say, for a lot of the fellows that never had that opportunity, but to understand, how do you change the process within your local community? And part of that is participating in city council, right? So, I would say for a number of the fellows, that was the first time they've ever done that. Completing a walk audit. So on the first session, we actually take everyone through a walk audit and aim so that they can ask questions, understand, what is even a walk audit? How do I do this? And then we give them the tools and we ask them to go out and actually do the walk audit in their own community, and then inviting a wide variety of participants to actually walk with them as well. So we try to cover a wide variety of different topics, but then also make them take action and do something with the knowledge that they're gaining, so that hopefully they can continue to do that, because that's our goal, is that Rachel will continue to be an advocate in Lynn County and her own community, and that we can continue to build more advocates, which we're fortunate. We actually have another fellow from Cedar Rapids this year as well. So very different modules that we cover. Obviously leadership we know is very important. We talk about why walking. We talk about different ways that you can build the movement, whether it's having open streets type of events, build a better block. So we try to bring in speakers to talk about that. We also do talk a lot about funding. So we bring in not only the Department of Transportation, which surprisingly they have a lot of money for any federal agency, I would say, and state agency. And a lot of those dollars can be used for trails and sidewalks. And improving bikeability. So we have Department of Transportation come in and talk about that. The Iowa Department of Economic Development Authority. So the State Economic Development people. Yeah, I never get their name right. They come in and talk about dollars that they have available and how you can even cross-use some of their funding. The Iowa League of Cities comes in and presents about, how do you work with city councils? And this year we're actually adding a panel based on feedback that will include a mayor, a city administrator, and a city council person to kind of, again, provide that perspective of what role that they have and understand the roles and responsibilities of those different policymakers as well. So it's pretty diverse. So it's not really all just focused on public health by any means. And then last year, we asked all of them, they received a small stipend actually through our partnership with the State Health Department to actually do projects in their community. So all of them had to come up with an action plan and identify what type of projects they were going to be working on. And so this is just kind of a list of a wide variety, education, updates to comprehensive plans by working with their NPOs, RPAs, reviewing sidewalk regulations, updating crosswalks, and you heard some of that, wayfinding signs. We have one fellow that's working on an educational video just to talk about what is complete streets and what does that mean. Safe routes to school, bike rodeos, community visioning, and story walks as well. So a wide variety of different ways that can improve walkability, that some of them are very low hanging fruit, which is a good thing, right? So that you can show right away. And some of them are much more comprehensive as well. I have one other video I'm going to show. So this video is actually Chris comes from Haberl Realty, and she's a vice president of development. And so she brought a very different perspective to the conversation, but I think you'll hear her, I think she learned a lot and took a lot away from participating in this. And I think it opened her eyes to things that they can do as they're developing communities that much more and building communities, how to make sure that walkability is something that's at the forefront and not something that's an afterthought as well.
The reason I was drawn to it in the first place is that I do development, and we uniquely now going to start to develop neighborhoods, as opposed, we used to just do one building. So we'd come into a spot, build a building, and go on. Well, now we get to develop neighborhoods. So what I loved about it is, how do I take what I learned there and start to, as we develop neighborhoods, and especially as we work in the downtown area where we have a lot of connectability, what do we need to do in those neighborhoods to use the knowledge of walkability to make those neighborhoods better, better suited for both families and seniors. So we're addressing not only the vitality that we want in the downtown area, but also the ability to include health issues for all of those people that are involved.
So I think, overall, the feedback was probably, I've been working in public health for probably almost 20 years now, and probably Sarah Taylor Watts and I both, said that this was probably one of the most positive feedback we've ever had from any program. I would say collectively the fellows found the program extremely beneficial and gained a lot of knowledge from participating, which was a win-win. We have a fellow from Preston, Iowa, which is a pretty small community, who is, she's a city council person and does some economic development for that community, and she has been just on fire and super excited about improving walkability. She has written a number of grants. They're finishing a number of trails in the community. They started a story walk on their community trail as well. And so we have lit a fire in her like no other. And she's not a public health person, and she even came to it thinking that this was all going to be about health, and she wasn't quite sure if that was the angle that she would be able to get people to buy into. I hear from her on a pretty regular basis about the stuff that they're doing, and I can't wait to get to Preston to help, even just celebrate what she's been able to do. So she's really rallied the community and even her county, Jackson County, to really look at walkability in a different fashion than I would say sometimes as public health people can do. So it's been really exciting, and we're excited to see what year 2 brings. We don't have as many public health professionals this year. We actually have a wide variety of either just local advocates who are really excited about improving walkability, and we have some planners, as well as some architects that are participating. So we'll see how dynamic the conversation gets for 2018 as well. So.
All right, thank you.
My name is Gina Uhing. I'm the director for Elkhorn Logan Valley Public Health Department in a small health district in Northeast Nebraska. And I am talking to you today about our Operation Heart to Heart program. My health district is this little highlighted section of the state that you can see to the right. I have a 4-county department, 57,000 people. I've been here for probably 12 years, almost 13 years, and back in 2011, we were asked to submit a grant application to the AstraZeneca Healthcare Foundation, and that's how this project was invented. Our leading industry is agriculture, which I'm sure holds true for many of the people on this webinar as well, being from rural United States. But we had some significant statistics where the heart attack rate in our service area had not quite doubled, but the state level had gone down, so it was very disproportionate. So, and then obviously too with the agriculture, we had a lot of insurance gaps with high deductible coverage, and due to the nature of farming and agriculture, a lot of our people don't get into wellness exams or really any appointments at all because of the traditional office hours. And most of our small town clinics are only open, like one afternoon a week or one morning a week. And so when we had done our community health assessment, we had learned that a lot of the agricultural workers are paying for the brunt of their healthcare services exclusively out of pocket because they never meet their deductible. So I sat here and kind of brainstormed back in 2011 and thought, what can we do to fill that gap and to really reach the farmers, the agricultural workers in a way that's convenient for them, that won't be a complete turnoff. So the Operation Heart to Heart program is a heart health focused program that uses case management services to give individualized education, support, and screening services to agricultural workers. I'm going to go a little bit more into detail with that, but first I wanted to point out, I did submit this to NACCHO last year, and we were awarded a model practice for this project, so it demonstrates that there is significant outcomes that have been achieved, and I'll get into the outcomes here later on in the presentation, but we did finally come up with a way to achieve the outcomes to the greatest ability that we could. And so with that, like I said, I wrote a grant in 2012 with the AstraZeneca Healthcare Foundation. The grant was $250,000 a year for 3 years. And the challenge was in the design, because I was talking with farmers. My husband's a farmer. We have a lot of people. Cumming County, Nebraska is one of the largest feedlot areas in the nation. So I have a lot of contacts, and I was trying to talk to the farmers and the feedlot workers on what we could do that would make them participate in a project, which they normally would not participate in. So designing the project was probably the biggest challenge. In 2013, the goal was originally to reduce the incidence of cardiovascular disease among agricultural workers, agricultural laborers exclusively. But it didn't take long for the general public, people who aren't working in ag, to hear about it. And then my phone starts ringing quite a bit, and other people who work in other sectors wanted to partake. So we did modify the goal in 2014 to include the overall rural population, but by and large, I would say probably 85% were the agricultural workers as we had intended. So the program had these components. We had 2 FTEs. We had a project coordinator, which was the health educator, and then we had a nurse, case manager, and RN. Plus, we also paid for an external evaluator to evaluate the project along the way. So I bulleted some of the duties of each position there for your review. Primarily, the nurse was spending her time doing the screening, exams, and the case management, while the health educator was doing a lot of the coordination and more of the office-based work. Other components, like I said, we had professional evaluation services. We did form an advisory council, which included healthcare practitioners from our area, as well as just various people from the agricultural sector that could kind of weigh in and help us to ensure that we were going down the right path and designing this in a way that would be appealing to our population. We did purchase and place numerous blood pressure kiosks across our service area, similar to those machines that you might see at Walgreens, where you stick your arm in there and then it spits out a little receipt with your blood pressure reading. But we placed those in agricultural places like sale barns, co-op, grain elevators, and so forth, so that the population that we wanted would participate. We developed an educational curriculum and a risk assessment tool and algorithm. All of that I'll get into a little bit more. And then we also did the business Take 10, which was a weight loss challenge. And I believe I get into that, all of these things, just a little bit more here in a few slides. I mentioned briefly some of the partners. These are the people who I give a lot of credit to for the success of the project. We had buy-in from the grain elevators, livestock sale barns, seed dealers, co-op, farm supply stores, farm equipment implement dealers, and so forth. We did this so that we could make sure that they would, help us with our outreach efforts, and that we could get into the agricultural population as much as possible. So we did a lot of mass mailing to the rural addresses. We marketed via stapled little slips onto elevator tickets during harvest. We had nurses who rode along in combines to talk about health with farmers. We had nurses walking the grain elevator lines, the weight lines during harvest. And for those of you who don't know what that's like, sometimes a truck could wait in line to dump for 3 hours. So we did screenings in line, we did case management in line. And this little cow here is this was kind of the, what made me have my epiphany with the program design, is that I came across this little cow with a heart on his head, and I thought, we need to talk heart health with all of these feedlot employees that are in our area. So this little calf here on the screen is who is made his appearance on all of our marketing materials, and it really got a lot of attention. It served its purpose. So we had program objectives, 14 of them. 11 of them were related to case management and biometric measures, and 3 of them were related to community education, which was just mass education across the 4-county area to anybody who wanted to listen. But by and large, we were focused on the case management and screening portion, which is why the brunt of our measures lied there. Of the 14, 12 of them were met or exceeded. So that is what helped us achieve model practice status with NACCHO last year. So I'm going to briefly breeze through the outcomes here, but on the top of the screen you can see each measure. I have listed whether it was a case management measure or a community education measure. I believe all of the case management measures are here first. We had hoped, or our goal was that 30% of case management participants who were overweight would reduce their body mass index by at least 1 point. These are, like I said before, by and large, these were agricultural workers. I believe 85% of them were, so we reached that by 38.6%. Next one was 30% of case management participants would have a 5-point improvement in their systolic or diastolic blood pressure numbers. We exceeded that by a lot, 69.4% achieved that. 50% would have a reduction in triglycerides by at least 10 points, 62%. 30% of case management participants would have a reduction in glucose. This was one of the 2 measures where we did not achieve target. This one only had a 23% improvement. And this is another one that did not. And this was the 5% of body weight loss. And we missed that by quite a bit. But going on to all the others, they were all met and achieved. This one was the goal of 30% increasing physical activity, and it went to 35.7. Here, 30% report increase in fruit and vegetable intake, and that was achieved by 45.1%. 60% enrolled in the program for at least 6 months. We were able to keep 74.5% on for that long. And 75% of case management participants achieved one of the goals that they had set for themselves, and that was met by 82.3%. Case management participants reflecting at least 10% knowledge increase on the nutrition education model. That went to 13.3%. And then, let's see here. Case management participants will reflect at least a 10% knowledge increase from baseline to post-test. That was 17.1%. And then now we're into the community education outcomes. 70% of the participants would reflect an increase in knowledge. That was 81.6%. 75% of blood pressure education participants were able to indicate a normal blood pressure, which was met at 91.3%. And I think that this is the last one. 20% of blood pressure screened and tracked participants with an initially high blood pressure value will have at least a 5-point improvement in either systolic or diastolic, and that was at 32.5%. So just because of the paperless nature of the presentation here, I did share my slides. I hope that you have opportunity to get those. I thought that they were going to be shared on a website, but on this screen here, the elvphd.org is my health department's website, and there is detailed information about the project. And if you call me or email me, I'd be happy to share any of the promotional materials. We have like a screening algorithm, screening tool, curriculum, and all that. But it's hard for me to share it via this type of delivery model here that we're doing today. But I do encourage you to look at the program. It has continued on since the funding for the project had ended in 2016. And over the course of those 3 years when we had funding from the AstraZeneca Healthcare Foundation, we were able to get credentialed with insurance companies. And so now we can bill insurance companies for the screenings and for the health education and case management portions of the project. And earlier on, I think one of my first couple slides had talked about the deductibles, but at least the screening portion of the project, we've been able, most of the insurance companies, even on those high deductible plans, have been covering the screening. So, that we were able to sustain the nurse case management portion of the project via insurance collections. What was the other thing that I was going to say? It had to do with the insurance angle. If you want me to share with you the screening codes and the education codes for screening, the ones that we've found to work the best, I'd be happy to do that as well. The project is not trademarked or copyrighted, so you guys can borrow, edit, do whatever you want if this is something that interests you, but we have really enjoyed it, and I think that it's made a big difference. I haven't pulled outcomes for about a year now, so the ones that I just shared with you were from 2017, but I think that it's probably heading on the same path. So if there's any questions, I'll answer those for you. Otherwise, please do email me, check out the website, call, and I'd be happy to answer any questions that way as well.
All right, thank you very much. Anyone who's ever worked in a local health department, $250,000 for 3 years. There's a lot of jealous people in the room.
Yes, we were very fortunate to get that funding. And AstraZeneca, just for your information, if you aren't aware, they do open up for grant applications every February. Usually they announce mid-January and the applications are due in February. And for those of you who write grants like I do, it's not the most painful of all grant application processes. It's completely online, and it has word limits in their text boxes. So even if you want to go on and on, like I tend to, it's not a terrible grant application to do. So I think it's highly competitive, but the application is pretty user-friendly.
All right, thank you again. And then I will now introduce our last speaker, Gianfranco Pezzino. Has worked in public health in several countries for over 30 years. He obtained his medical degree from the University of Bologna, Italy, and his master's degree from Johns Hopkins Bloomberg School of Public Health. He is a senior fellow and strategy team leader at the Kansas Health Institute, Topeka, where he oversees a wide variety of projects, including assisting local health departments in their accreditation readiness activities and investigating options to improve childhood immunization in the state. Dr. Pezzino is also the co-director of the Center for Sharing Public Health Services the national program funded by the Robert Wood Johnson Foundation and hosted by the Kansas Health Institute. Dr. Pezzino also functions as County Health Officer for Shawnee County, which is where Topeka is located. So I will turn it over to him.
Thank you. Good morning, everyone. It's never fun to be the last thing between you and lunch, or even work between you and going home. So I try to make this brief and hopefully a little bit entertaining. You know who I am. You may not know about the Kansas Health Institute very much. We are a nonprofit, independent public health institute in Topeka, and we do mostly work on public health research and policy development. So I was on a communication training about 2 weeks ago, and I came home with a very clear message that the training organizers convened to us, which was, you've got to use stories. Enough with these PowerPoint presentations where you just have words and you have no story. You've got to use stories. And that's quite a challenge. Because how you make a story out of something like cross-jurisdictional sharing or the modernization process in Kansas. So here is my attempt to do that. You are my test audience for this new model. Let's see if it works or not. So every good story starts with once upon a time, right? So once upon a time, there was Nurse Edna. We're talking about 100 years ago. Edna was working in Western Kansas under the direction of Dr. Samuel Crombine. Some of you may have heard the name. Dr. Crombine was one of the national pioneers of public health, the guy who invented the fly swatter. He understood how disease was transmitted. And so back then, things were a little bit different from today, right? The health department was probably a little cubicle, maybe in a courthouse, maybe standalone in the field, and people were not moving around very much. If they were doing that with these things that they called cars back then. I'm not sure we would call them cars today, but they really couldn't go very far and very fast. So problems tend to be localized in one area. And most problems, most of what Edna was doing was control of communicable disease and education about environmental issues like clean water, clean sanitation, and so on. There was a time when we could celebrate the fact that in any one year we only had 186 deaths from TB. So imagine that today. It's unthinkable how many deaths from TB we have. It's usually very few, if any, in any one year. There were health departments that were created in Kansas after the one where Edna worked opened. And usually they were based in counties. And the rule of thumb was that you should be able to go the health department to the county, town, and back to where you live in one day on horse. That's how they created those boundaries. And so that's the result of that. It's 105 counties in Kansas and 100 local health departments. Every county is served, so we have 2 multi-county health departments, but you can see the fragmentation just from the map. But again, it goes back to the era when people were moving on horse. Now, what Edna was doing was really addressing the immediate causes that could help people stay healthy. So primarily some education about sanitation, some control of transmission of infectious disease and immunization, things like that. So you are probably familiar with this pyramid here, where you have this, what we know today, the socioeconomic factors at the base, and then the higher you go and the more clinical and individualized interventions are. And that's what Edna was really doing, was working here at the tip of the pyramid. One client at a time, one person at a time. Edna retired, and Nurse Brianna took her place. And so fast forward, we are in the 80s, more or less. Things were quite different. Forget about all those deaths from TB, pneumonia, diarrhea. Now we're talking about heart disease, like in the last presentation, cancer, stroke. That's what was killing people in the 80s. So the whole structure and the whole set of skills that Edna and people like her had developed suddenly became challenged by a shift in the epidemiology of what caused disease and death in our communities. And so people came up with this brilliant idea that we shouldn't just look at the leading causes of death like heart disease, cancer, stroke, diabetes, but people asked, what causes that? What's behind that? Why are people dying from heart disease, cancer, stroke? And they came up with the concept of leading versus actual causes of death. And on the right, you can see that the actual causes of death for those 5 conditions, for example, were actually tobacco use, poor diet, and physical inactivity. So instead of focusing on the immediate leading cause, now if you really wanted to do prevention, you need to start working on those leading causes of death, most of which, by the way, at least those at the top, were behavioral related. Were related to behaviors that people adopted and that in turn would cause them to become sick. Quite a shift from the time that Edna was working. But now, this part at the top remains there, right? Brianna is still doing immunization, still doing STD screening and treatment. But she had to address a huge variety of other things like lifestyles, community health education, and policies. Policies to make our communities more walkable, to make our communities more healthy, to make the healthy choice the easy choice. So again, quite different from the way that things were 50 or 60 years earlier. And the more people studied these issues, the more they actually expanded and they broadened the spectrum of factors that affect health. And what we know today is actually 60% of our health is related to social and environmental and behavioral factors. It's a complex interaction of factors that are not really related to healthcare or to your genetics so much. That's only 20%. 60% is the environment, essentially, where we live, and the lifestyles that we choose to have, in many cases, as a result of those environments. And so all of a sudden, health is not just health anymore. If you want to be healthy and you need to change your environment, then you start starting to talk about working in transit, agriculture, energy, education, business. All those things are going to result in a healthy or less healthy community. So not only now we have these policies, the community health education, now we have to address the social determinants. That was a little too much for Brianna. She didn't feel that she had the skills to do that, and she felt overwhelmed, and so she quit. And she was raised by Joaquin. Joaquin came to the health department with a different background. He was active from the community, and he had a lot of good connections in the community. He was not a nurse, although he was married to a nurse and he appreciated the work that the nurse does. He actually had a degree in community psychology. And he saw his role primarily as one of making connections in the community. Sure, you still have to give the shots, maybe someone else can do it, maybe you have to do it, that's still important. But his primary role now was becoming one of the chief health strategists, where he and his health department would be involved in less direct care and more in becoming a catalyzer and the convener to have those conversations with all those sectors that now we know affect health. Thinking upstream and not just one patient at a time. To do that, Joaquin has to create a different infrastructure. He needs to have different workforce. He needs to have more information, more data. He needs to have more flexible and sustainable funding. Not easy. There are several challenges to reach to the point that Joaquin wants to reach. Funding is definitely one of them. What you don't see from the pie, first of all, this is a very small pie. Kansas has one of the lowest state level funding in public health in the entire country, so money that comes directly from state general fund. But the other thing you can notice is the fragmentation. And each of these slices often is money that can be used just for a particular program or another, but not for the kind of broad connectivity that the chief health strategy like Joaquin wants to achieve. Another thing to notice here, look how much money comes from fee-for-services. And many of those fee-for-services are related to individual services that are provided the health department. So if Joaquin really goes down the road of maybe shifting some of the clinical services to other entities and becoming the chief health strategist, the money is going to disappear. So huge problems with funding. Then somebody came up with this brilliant idea of issuing standards and measures for accreditation. And when Joaquin looked at that in his relatively little health department where he worked, he said, there's no way I can do that. Not in a million years. I don't have the capacity to do these things, not by myself. In part because of the fragmentation that we still have. Remember the 100 health departments, and in fact, they still exist, each and every one of them, 100 years later. Now, that's when people were moving on horse, but we don't anymore, right? And when you look at those standards and measures, Joaquin realized that, I need to have an epidemiologist. Even if I had the money to find an epidemiologist, where are we going to find 100 epidemiologists to put one in each health department? And probably some of the departments would need more than one. And so that fragmentation was another obstacle. Everyone was fighting for the same money, is fighting for the same money and for the same resources. Looking at the workforce composition also gives Joaquin a little bit of a pause. You can see here the gray bars is the proportion of health departments in Kansas who employ people with that kind of qualification. So you can see the vast majority of health departments do have nurses and administrators, they have a manager. But when you come down to things like epidemiologists, community health worker, health educator, environmental health worker, those are much more rare to find in Kansas. And this is the characteristics of the Kansas executives in local health departments. You can see Kansas on the left and the national on the right. In very few words, we have a leadership at the local level that is primarily white female nurses, middle-aged. And again, Joaquin has a lot of respect for nurses. He's married to one, but he understood that those people may not have the right skills that he wanted to have now for his health department. And then one day, the Kansas Association of Local Health Departments came to the rescue. And they decided that they would adopt a vision based on their underlying principle that everyone in Kansas, no matter where they live, should be entitled to receive the same public health services. That's their underlying principle. CAL decided that they would adopt the vision of a system that can achieve optimal health by providing foundational public health services. Those are the key words, foundational public health services. So the question was, what is really at the core of public health in the 21st century that every citizen in our state should expect to find when they go to a health department? And CAL developed also some visions and strategies how to get to that point, including the definition of what those foundational public health services are, the understanding of some potential funding mechanisms and governance mechanisms that we really need those 100 health departments still in a state like ours and other things. And the way that CAL decided to do that was through a collaborative system. It's something called the Public Health System Group, which is a coalition of all these organizations that you see there, including Mine Institute, but you have local public health, the state public health, the Public Health Association, the universities, and so on. That group had been in existence already for about 10 years when CAL in 2015 adopted a motion. And the group decided to take the charge to explore that option of modernization for the system of public health in Kansas. So the activities were in-depth research and assessment to determine the best model for public health in Kansas, and discussion of options for policy, governance, and funding structure. This is one of the results of the group. You probably, many of you, I hope, are familiar with this chart. It's a little bit of a variation. There is one made at the national level, but now every state, or at least many states, are going through the process of adapting this chart to their own needs. So what you see here is the foundation of public health services. It's this entire box. They include some foundational capabilities, so skills essentially, and capabilities that need to be present and that affect all the programs that the health department runs. And then some specific foundational public health areas, these 5 boxes here. That's the core. That's what has been developed now in Kansas, and with the agreement and the input from all health departments. And these things inside the box is what ideally, if this model succeeds, you would expect to find in every health department in the state. Now, we do realize that there are other things that health departments do, and some of them are absolutely necessary in certain localities. Those are the things that we call they are above this line here. So there are additional services that may be specific to certain communities, and they should be provided, but they're not foundational in the sense that every health department should have those services. So this was one of the results of the work in 2016 and 17. Then what we also did was some assessment of the current capacity of local health departments to provide those services and those foundational public health services. As you can see here, when you divide by frontier, so by population density, essentially, when you compare the gradient from frontier, rural, semi-urban, urban, you can see, as not as a surprise, I assume, that the more you go towards the urban side, and the higher the capability and capacity. And the fair question is, actually that question comes later, I'm sorry. Budget question, that's something else that we asked. So you can see a wide variety, a wide range of budget. If you look at the average, it's 1.1 million, really? On average, 100 health departments in Kansas have that? Well, that's because we have a couple of outliers that are multi-million health departments. But really, the median is 434. So I'm an epidemiologist by training. The older I get, the more I hate averages because they're so misleading. No, the average health department in Kansas does not get more than $1 million in funding. 50% of them get less than $400,000, more or less. And the minimum is $73,000. So huge variety, the maximum $50 million. Budget per capita. Now, if you think about the budget per capita, it's another way to look at an average, right? It's the average money that's spent per person in the state or in the county, in each county. You can see also huge variability from $6.78 to $200. Now, where do you expect the minimum per capita money takes place? In larger departments or large counties with more population or small counties? Per capita. The highest per capita is actually in the least populated counties. Makes sense, right? You still have some money to run the health department, but when you divide the money by the few people who live in that jurisdiction, it's a lot of money per capita. But it's still not a lot of money to run a health department. Same thing for the FTEs, huge variability. Look at the median, 5. 50% of health departments in Kansas operate with fewer than 5 FTEs. So how is that related to capabilities? That's a question that we ask. So are budget and staffing associated with higher capacity and capability in health departments? Great our operating budget and FTEs are, but the per capita spending is not. So it's not the issue of how much money per capita you put into the system. The issue is, do you have enough mass of funding, enough volume that can sustain a viable health department? Is the cumulative amount of resources available, not the per capita level, that makes a difference? And here is the way it works, actually, if you want to chart for that. This is the average budget by population density. You've seen that, I think, in aggregate. Now we divide it by population density. So on average, an urban health departments in Kansas has $8 million budget. And on average, a frontier has $230,000 per year budget. How does it translate into per capita? Here it is. Look at the per capita budget in frontier versus the urban. Now, in my opinion, there is no way in 100 million years that you can bring this column up to a level where you can actually meet the needs without increasing a per capita budget in a way that will be absolutely unsustainable. This is already unsustainable. But you can't just level out that difference by increasing the amount of budget of those frontier countries without getting into a per capita budget that would be out of the chart. So how much would it cost to implement the model of foundational public health services in Kansas? Well, if we keep the same system, this is work done by Burr Consulting for us. If you keep the same system, at the minimum, we would need an additional $15 million. I think that's an underestimate. I personally think it's going to be more than that. For one thing, that doesn't include additional money for the state health agency. This was based on work and numbers collected from different local agencies in the state. I think it's an underestimation. You could probably save up to $5 million through collaboration and resource sharing. So going, instead of having 100 epidemiologists, going to a regional model or going to a consolidation model for the smallest health departments, you could save up to $5 million. Some key considerations while we move on that path. Our public health laws and systems are still stuck on version 1, where Edna was working with Dr. Crombine 100 years ago. There is a need for new models and policies, but there is not always a full agreement on what those models should be. There is still a profound budget crisis in the state. I don't know how much you have been following the events of Kansas and the infamous Kansas experiment on the budget. But the result is that we're still recovering, probably takes several years for recovery before we can go back to the level of 5 or 6 or 7 years ago. Not really to the level that some of us think we need. And there is still this tension between efficiency and effectiveness increase and home rule model. Again, I showed you it's unsustainable. I mean, the numbers are pretty clear, but yet the home rule concept is so strong, and I'm sure I'm speaking to the choir here, you're familiar with that concept, that it's hard to convince people that they can still retain their independence and their control, even if they share an epidemiologist with 5 other health departments. Something more recent, we are the recipients of a grant from the, how many of you know the FINCI, Public Health National Center for Innovation? It's a kind of subset of the FAB, the Public Health Accreditation Board, and they're looking at modernization roadmaps for different states or innovation in public health for different states. In Kansas, they received some funds to run a little pilot project on this modernization model that I described to you. One of the things that we are doing, we actually have a group of 4 health departments that are going through the whole process of looking at each and every one of the foundational public health services and see what's the current capacity, what's the desired capacity, how we can achieve that, and is there a way to maximize the use of resources through sharing. So that process is still ongoing. It should be done in about 6 months, I think. So where are we going from here? Joaquin is still working in the health department, but he's really not sure which direction the future is going to take him. As you probably know, some million years ago, there were dinosaurs roaming Earth. And then the most accredited theory is that a major asteroid hit Earth. And what destroyed the dinosaurs was not the direct impact of the asteroid. Many survived that. What destroyed the dinosaurs and led them to the extinction was that the environment around them changed so much that they couldn't survive anymore. They were just extinct. But some of them were able to evolve. They became smaller, some of them grew wings. They became more adaptable to the new environment, and evolution then continued. I think that's the stage that, at least in Kansas, and I would argue in many other states, we are at this point. We are at the fork where we can decide whether public health as we know it is going to be extinct in a few years, and someone else will do those things that we thought we should do, or it's going to evolve in something that can still survive in the new environment. That's it.